Welcome back to the deep dive. Today, we're really setting aside the sort of generalized advice you hear everywhere. We're going deep, really deep, into the microscopic machinery that literally builds our blood. We are tackling the essential factors needed for blood formation, the haematinics, and we have a mission today to really master this information like the elite professionals in the field do. This isn't just about, naming a few vitamins. It's about understanding the core regulation, the pitfalls, the surprising links between iron, vitamin B12, folic acid, and that master hormone, erythropoietin.
Exactly. That's the shift, isn't it? We want precision today. We want to understand why. Why, for instance, can a common heartburn pill just completely negate months of iron treatment? Or why can one simple vitamin deficiency cause irreversible neurological damage while another one doesn't touch the nerves? We'll be focusing hard on the absorption mechanisms, the metabolic pathways, the real guts of how these four cornerstones work.
Okay, before we zoom right in on those specifics, let's just quickly set the stage. Let's define the core problem we're ultimately trying to solve here. Anemia. Most people just think low blood,
Right.
right? But that really misses the whole picture.
It does. Anemia fundamentally is a disturbed balance. Simple as that, almost. It's when that ratio, the production of red blood cells versus their destruction, it just goes out of whack. And we can sort of break this down into three main buckets, cause-wise. First, you've got blood loss. Acute or chronic, pretty self-explanatory. Second, and this is where our deep dive really lives today, is impaired formation. That could be a deficiency of our key players, iron, B12, folate, or it might be a deeper bone marrow issue, or maybe a lack of that crucial stimulating hormone, erythropoietin.
And the third category, what's that?
That's increased destruction, what we call hemolytic anemia. Basically, the red cells are getting destroyed prematurely, faster than the body can possibly replace them. But for today, we're laser focused on fixing that formation problem by mastering these haematinics.
Okay, let's unpack this then. Starting with the absolute cornerstone, iron. The history of iron is just fantastic when you look into it. Humans somehow knew it was vital for strength ages before we could prove it in a lab. The source material mentions lauha basma, calcined iron, being used centuries and centuries ago in ancient Indian medicine.
It's incredible intuition, isn't it? And you see it with the ancient Greeks, too. They actually dedicated iron to Mars, the god of strength. And they used iron preparations to treat, weakness, debility. It's almost a perfect guess at its function. And that intuition, it was finally confirmed scientifically in, 1713? When iron was definitively proven to be in the blood.
Which eventually led, down the line, to Blood's pill, that famous mix of ferrous sulfate and potassium carbonate in the early 19th century. Really the start of modern iron therapy.
So we know it's essential, but for mastery, like we're aiming for, we need the specifics. Where does it actually live in the body? What are the percentages? Because it's definitely not all just floating around in the blood. That distribution is absolutely key to understanding its roles. An average adult carries somewhere between 2.5 to 5 grams of total iron. The average is usually pegged around 3.5 grams. And typically, men have a bit more, maybe 50 milligrams per kilo body weight, compared to women at around 38 milligrams per kilo. But look at the breakdown. That tells the real story of the body's priorities. A massive 62% is actively working, carrying oxygen as part of hemoglobin, HB. That's the real workhorse fraction.
Okay, 62%. That leaves, just over a third for everything else?
Exactly. Then you've got about 25% dedicated purely to storage. This is mainly as ferritin and hemosiderin, these storage complexes we'll get into in a sec. Another 7% or so is held in myoglobin, specifically in the muscles, helping with local oxygen transport right where it's needed for muscle function.
Right, and that last little bit, the final 6%. You could argue this small amount is actually the most critical when we think about deficiency beyond just anemia.
Precisely. That remaining 6% is what we call parenteral iron. This is the really crucial, often overlooked iron. It's found as prosthetic groups, basically essential parts, within vital cellular enzymes. Things like cytochromes, peroxidases, catalyses, key mitochondrial enzymes, the absolute energy factories inside every single cell.
So if the 62% in hemoglobin is about carrying oxygen around the body, then this 6% parenchymal iron is about making sure the cells can actually use oxygen and energy to survive and function.
Absolutely. You've nailed it. While anemia, the lack of oxygen carrying capacity, is the most obvious clinical sign of iron deficiency, severe deficiency hits practically every cell in the body because those vital cellular enzymes just can't work properly without their iron component. That's the difference, isn't it? Knowing the main symptom versus truly understanding the systemic impact.
Let's nail down the hemoglobin math then, because this seems fundamental for figuring out treatment doses. Why is that 0.33% figure so important?
Right, hemoglobin itself is this incredibly sophisticated molecule. It's a protoporphyrin structure, and it has 4 iron-containing heme bits. Just by mass, that works out to iron being 0.33% of hemoglobin's weight. And this simple ratio dictates all the therapeutic calculations. It means if you lose, say, 100 milliliters of blood, poof, you've lost 50 milligrams of elemental iron right there. And crucially for treatment, to raise a patient's hemoglobin level by just 1 gram per deciliter, 1 GDL, you need to provide roughly 200 milligrams of elemental iron. This calculation isn't just academic, it's the bedrock for figuring out how long someone needs treatment. It helps us move beyond just, throwing pills at the problem. It helps define the total deficit that needs fixing, including replenishing those stores we mentioned.
That makes complete sense. Okay, now let's look closer at that 25% dedicated to storage. How does the body manage to keep this highly reactive metal iron available but safely inactive?
Well, iron must be stored in its ferric form, that's Fe plus F, and not the ferrous Fe2 plus form, that's just too reactive, too dangerous, floating free. So this ferric iron is combined with a specific protein called erythropoietin, and together they form ferritin. Think of ferritin as the body's main iron savings account. It's highly usable, it's readily accessed when needed, and it can hold a lot of iron when it's fully saturated. Up to 30% of its own weight can be elemental iron.
Okay, a savings account. Where are these accounts primarily kept?
The main storage sites are the reticuloendothelial cells, or RE cells. These are basically the macrophages, the cleanup crew, found in the spleen, liver, and bone marrow. But you also find significant amounts in hepatocytes, liver cells, and myocytes, muscle cells. Now, when ferritin molecules start to clump together or aggregate, or maybe begin to degrade slightly, they form something called hemosiderin. Hemosiderin is different. It's more sequestered. It's not easily or readily reutilized. It's like a less accessible, more solidified long-term store.
So, if we're really aiming for that mastery level understanding, the key insight here is that when we treat a patient for iron deficiency, we're not just trying to get their HB level back up. We're also consciously aiming to replenish that ferritin savings account, because we know deficiency hits those core cellular enzymes too.
Exactly right. We absolutely have to remember that low ferritin levels, even if the hemoglobin number is still holding on, clinging to the low end of normal, that low ferritin signals a systemic deficiency that is already impacting cellular metabolism right across the board, long before the classic anemia symptoms might become severe.
Right, we know where iron lives now. Let's talk about how the body actually manages to bring it in and then hold on to it so tightly. Because this metal is so critical, the body is famously, almost notoriously conservative with it.
That conservation is precisely why the daily requirement is surprisingly small compared to many other nutrients. An adult male, on average, only needs to absorb about 0.5 to 1 milligram daily, just to balance out the tiny amount lost normally. Now, for a menstruating female, because of monthly losses, that need basically doubles to 1 to 2 milligram absorbed daily.
And the requirements just skyrocket during pregnancy, don't they?
Oh, dramatically. During those last 2 trimesters especially, the required absorption leaps up to 3 to 5 milligrams every single day. The total demand over the whole pregnancy, you're talking around 700 milligrams overall for the baby, for expanding the mother's own red blood cell volume, plus compensating for blood loss at delivery. That total is pretty much impossible for most women to meet just through diet alone.
Let's quickly touch on diet then, just to put that absorption challenge into context. What are the good and bad sources?
Well, the rich sources include things like organ meats, liver is a classic egg yolk, oysters, and certain vegetables like dry beans. Then you have medium sources, standard meat, fish, spinach, even bananas have some. And the poor sources, it's important to remember, include things like milk and root vegetables. They just don't offer much iron. But here's the thing. The average daily intake is actually substantial, maybe 10-20 milligrams of iron.
Okay, intake 10-20 milligrams, but we only need to absorb 1 or 2 milligrams. Here's where we get into the real nuts and bolts, the elite understanding part. We only absorb a tiny fraction, mostly way up in the upper intestine. And the body uses 2 completely separate absorption pathways, right? And they're not equal in efficiency at all. This is where it gets really interesting.
This distinction is absolutely critical for understanding problems. Pathway 1 is like the express lane, hemi-iron. This comes directly from animal sources, meat, poultry, fish. And up to 35% of this hemi-iron can be absorbed. It's highly efficient. It gets taken up directly into the mucosal cell by a specific carrier protein called HCP1. And crucially, this uptake doesn't depend on whether the iron is dissociated from anything else or whether it's reduced. It just gets pulled in fast.
Okay, heme iron is easy. Pathway 2, then the inorganic iron, that's the really complicated route, isn't it? And that's where most of our absorption issues lie.
Exactly. Inorganic iron absorption averages only about 5%, much, much lower. And most of the iron in a typical diet, especially plant-based iron, is in the ferric form F3 plus War. Now, for this ferric iron to even have a chance of being absorbed, it must first be broken free, dissociated from whatever dietary complexes it's bound to. And then, most importantly, it absolutely has to be chemically reduced to the ferrous form F2 plus before the intestinal cell can actually take it in.
It really sounds like a highly secure checkpoint system the body's set up.
It is. And the process hinges on two key transporter proteins. Once the iron is finally in that required ferrous Fe2 plus state, it gets carried into the mucosal cell, the cell lining the intestine, by the divalent metal transporter 1, DMT1. Think of DMT1 as the dedicated gatekeeper. It only lets ferrous iron through the front door. Now, once inside the cell, that iron faces a choice, which we'll get to with the ferritin curtain idea. But if the body needs that iron, and it's destined for the bloodstream, it has to pass through a second single exit gate. This one's called ferroportin, FP, and it sits on the other side of the cell, the basolateral membrane. These two transporters, DMT1 and ferroportin, they're like the immigration officers for iron. And their expression, how many of them are present, is tightly regulated based on the body's current iron levels and needs.
Okay, that need for reduction F3 plus down to F2 plus, that immediately explains why things like stomach acid and vitamin C are such huge helpers for absorption.
Absolutely. Acid, specifically stomach acid, HCl, is a primary facilitator. Why? Because it creates the low pH environment that favors both the dissolution of iron from food and that crucial chemical reduction of ferric to ferrous. If you lack stomach acid, say due to medication or surgery, you severely hamper inorganic iron absorption. And reducing substances like ascorbic acid, vitamin C, or certain amino acids with SH groups, they perform the same chemical reduction step. Even just eating meat helps inorganic iron absorption, partly because it stimulates more HCl secretion in the stomach.
Conversely then, what slams the brakes on this whole process? What blocks absorption?
Alkalis are the biggest impediment by far. Things like antacids, which we'll see later in the case study, they raise the pH, rendering the iron insoluble and directly opposing that necessary reduction step. Phosphates, which are rich in things like egg yolk, and phytates, very common in cereal-based diets like maize and wheat. They form insoluble complexes with the iron, basically locking it up so it can't be absorbed. Even some common antibiotics, like tetracyclines, can grab onto iron and impede its uptake.
We've established that free iron is toxic, which explains why the body has this amazing self-regulating defense mechanism built right into the gut lining itself. It's called the ferritin curtain. Sounds like a temporary shield against getting too much iron.
That's a perfect way to think about it. The body is constantly walking this tightrope between getting enough iron and avoiding toxicity. So the iron that successfully gets inside the mucosal cell via DMT1 has a crucial fate decision. Option 1, exit immediately through ferroportin into the plasma if the body needs it. Option 2, be oxidized back to the ferric form, Ff3+, and stored locally, right there inside the mucosal cell itself, as ferritin. This locally stored ferritin is the curtain.
And the real genius of this system is tied to how short-lived those intestinal cells are, right?
Exactly. These mucosal cells have a very rapid turnover. They get sloughed off into the feces every 2 to 4 days. So if the cell has trapped the incoming iron by storing it as ferritin, meaning the curtain is down or active, that iron is simply lost from the body when the cell is shed. It's a brilliant passive mechanism to prevent chronic iron overload. And the regulation is exquisite. If you're iron deficient, the body signals the mucosal cell not to make much ferritin, prioritizing transport out of the plasma via ferroportin. The curtain is up. However, this block isn't foolproof. It can be overwhelmed as someone consumes a truly massive toxic dose of iron all at once.
Okay, so the iron successfully navigates DMT1, bypasses the ferritin curtain if needed, and exits via ferroportin into the plasma. But it can't just run free out there because it's still dangerous.
Absolutely not. It's immediately chaperoned. Enzymes quickly convert it back to the ferric form, and it gets tightly bound to a specific transport glycoprotein called transferrin, TF. Transferrin is the dedicated iron taxi service in the blood. What's really remarkable here is the turnover rate. The total amount of iron actually circulating in the plasma at any one time is tiny, only about 3 milligrams. But this small pool is recycled incredibly fast, about 10 times every single day. That results in a massive 30 milligram daily turnover, mostly shuttling iron from storage or absorption sites to the bone marrow.
That constant recycling makes sure iron gets where it's needed most urgently, the bone marrow, for making new red cells. How do the target cells, like those in the marrow, actually grab this transferrin-bound iron?
They use a specific receptor on their surface called the transferrin receptor, TFR. This receptor binds tightly to the transferrin iron complex. The whole package receptor plus transferrin plus iron is then pulled into the cell through a process called receptor-mediated endocytosis. Once inside the cell, a change in pH within an internal vesicle forces the iron to detach. The iron is then released to be used, for example, in hemoglobin synthesis. And importantly, the TFR and the now empty transfer molecule are then recycled back to the cell surface, ready to pick up another load of iron. And this mechanism gives us a really useful diagnostic clue. In states of iron deficiency, or when red cell production is really ramped up, brisk erythropoiesis, the developing red cells in the bone marrow will selectively express many more TFRs on their surface. They basically put out more receptors to efficiently vacuum up every last bit of the limited available iron. Finally, just to round off the dynamics, we need to touch on excretion, which really just reinforces how incredibly highly the body values this element. It's almost perfectly conserved. The daily loss is minuscule, only about 0.5 to 1 milligram in adult males. This tiny amount is lost primarily through the constant shedding of cells from the gastrointestinal lining, from the skin, a tiny bit in bile, and a very small number of lost red blood cells. For females, the average daily menstrual loss accounts for that slightly higher requirement, adding maybe another 0.5 to 1 milligram per day on average. The key point is, the body simply does not have an active regulated excretory pathway for iron like it does for, say, sodium or potassium. Once it's in, it's basically in for good unless you bleed.
All right, we've got the mechanics down. Let's move to the practical side, treating deficiency. Oral iron is nearly always the first step, but patients often complain bitterly about the side effects, don't they?
They do, and oral iron is always the preferred first-line approach. The key principle to grasp here is that the simple dissociable ferrous salts, the Fe2+ ones, are generally better absorbed and definitely cheaper than the ferric salts. And the critical clinical takeaway, the thing to tell patients, is that the most common side effects, that stomach irritation, the nausea, the constipation, they are directly related to the total amount of elemental iron being taken in each dose. It's not usually about the specific type of salt.
Ah, okay. So if a patient complains bitterly about nausea from, say, ferrous sulfate, switching them to a different, maybe more expensive ferrous salt that contains the same amount of elemental iron might not actually help them feel better?
It often doesn't, and that's why really mastering these basics is so important for guiding patients. The solution might actually be to reduce the dose per administration, maybe take it more frequently in smaller amounts, or adjust the timing relative to food, not necessarily just switching to a fancier, pricier formulation.
Let's quickly break down the main oral salts available then.
Sure. Ferrous sulfate is the old standby, the historical standard, and definitely the cheapest. It contains about 20% elemental iron when it's hydrated, or 32% if it's the dried form. Ferrous gluconate offers a bit less elemental iron, around 12%, and ferrous fumarate is slightly less water-soluble, but packs a good punch with 33% elemental iron.
What about some of those other forms you see marketed, maybe claiming better tolerance, like carbonyl iron?
Right, carbonyl iron is interesting. It's essentially highly pure metallic iron powder, very dense at 50% iron by weight. The claim for better tolerance often comes because it's absorbed more slowly, potentially over a longer stretch of the intestine. But the trade-off is that its overall bioavailability, how much actually gets used, is generally only about 3/4 that of standard ferrous sulfate. You also see things like colloidal ferric hydroxide, often used in liquid preparations, also around 50% iron. And then there's a whole range of complex forms: ferric hydroxypolympalcos, ferrous succinates, ferrous minerates, often marketed heavily on better tolerance, but usually they're significantly more expensive, and the evidence for dramatically superior efficacy or vastly better tolerance isn't always robust compared to just managing the dose of basic ferrous salts correctly.
Okay, speaking of efficacy and cost, the market is absolutely flooded with combination preparations, isn't it? Iron mixed with B12, folic acid, often zinc, copper, maybe a whole slew of B-complex vitamins. If we're aiming for that elite, precise practice, what's the general consensus on these all-in-one hematinic products?
Well, the consensus, especially from advisory boards and expert groups in places where these combo products are really common, it's pretty strong. There's generally a recommendation against routinely including things like B-complex vitamins or zinc and standard iron and folic acid preparations for anemia. The thinking is, if a patient is genuinely deficient in multiple haematinics, say iron and B12, they should be properly diagnosed and treated specifically for each deficiency. These shotgun combination products often just add complexity and cost without necessarily providing a clear clinical advantage over using simple, cheaper ferrous salts and then adding specific folate or B12 if they are actually needed based on testing.
Right, targeted therapy. Let's define the proper dosing and timing for standard oral iron treatment then.
The established therapeutic dose, the amount needed to really drive the bone marrow response maximally, is generally considered to be 200 milligrams of elemental iron per day. This is usually best tolerated if divided into, say, 3 separate doses throughout the day. Now, for simple prophylaxis, like preventing deficiency during pregnancy, a much lower dose of 30 milligrams of elemental iron daily is typically the standard. As for timing, we know absorption is significantly better on an empty stomach. Why? Because that stomach acid helps with the reduction of ferric to ferrous iron. However, taking iron on an empty stomach dramatically increases the likelihood and severity of those nasty side effects, the nausea, the vomiting, the epigastric pain. So in practice, it's often a trade-off. We might have to sacrifice some absorption efficiency by recommending the patient takes a smaller dose with or immediately after a meal. The goal is to ensure they actually take the medication consistently rather than stopping it because it makes them feel sick.
And those adverse effects, are they generally dangerous or just really unpleasant and irritating?
For the most part, they're highly irritating, but not dangerous systemically. The most common complaint is actually constipation. This is thought to be due to iron's astringent action on the gut lining, sort of tightening things up. Diarrhea is less common, but it can happen too, probably due to direct local irritation. The key is really managing patient expectations. And often the best approach is to start with a low dose, maybe just once a day, and then gradually increase it over a week or two towards that target 200 milligram daily dose. This helps the gut adapt and often improves tolerance significantly.
Okay, so when does the decision get made to abandon oral therapy altogether and switch to injectable iron, what we call parenteral iron?
Parenteral iron is really reserved for specific situations where oral therapy has failed or is clearly inappropriate. This includes patients who have truly severe oral intolerance, like intractable nausea, vomiting, or severe bowel upset that just doesn't improve with dose adjustments. Also, patients with clear evidence of malabsorption, maybe they have severe inflammatory bowel disease like Crohn's or ulcerative colitis or chronic intestinal inflammation from another cause that prevents uptake. Noncompliance is another factor. The patient simply cannot or will not take the oral pills consistently. Severe deficiency, especially when paired with ongoing chronic bleeding that outpaces oral replacement capacity. And critically, it's often necessary when used concurrently with erythropoietin therapy in patients with chronic kidney disease, as their iron needs can be immense.
Right. And when we're treating systemically with injections, we need to be much more precise about calculating the total iron deficit, right? Including replenishing those stores we talked about.
Yes, absolutely. There's a standard formula used to estimate the total iron requirement in milligrams. It's roughly 4.4, multiplied by the patient's body weight in kilograms, multiplied by their hemoglobin deficit in grams per deciliter. That formula aims to cover both replacing the iron needed to correct the functional HB deficit and providing enough extra to replenish those crucial ferritin stores. Now, the absolute fundamental constraint with injectable iron is this. You cannot inject simple ionized iron salts, free ferrous or ferric ions. Why not? Because they would instantly precipitate proteins in the blood and tissues, and free iron itself is intensely toxic when injected directly. So we must use specialized formulations where the iron is complexed, bound within an organic molecule, designed to release the iron slowly and safely once inside the body.
Okay, let's do that deep dive into the main injectable formulations then. Focusing on how they've evolved in terms of safety and convenience, what was the old standard?
The traditional option, the one used for over 50 years, is iron dextrin. It's a high molecular weight colloidal solution, basically iron particles coated in dextrin. It's unique because it's the only one that can be given intramuscularly, But IM injection is tricky. It requires the deep Z-track technique to try and prevent the solution from leaking back up the needle track and causing severe, often permanent, brown staining of the skin. The major liability with iron dextrin, though, is the dextrin component itself. Dextrin is known to be antigenic, meaning it can trigger immune reactions. This gives iron dextrin the highest risk of serious anaphylactic reactions among all the available IV iron forms. Plus, studies show that maybe 10 to 30% of an IM dose can remain trapped locally in the muscle for weeks, unavailable for use. So you often had to administer about 25% more than the calculated dose just to account for this trapped fraction.
Wow. So less effective, riskier, and painful with potential staining. Okay, clearly there was room for improvement. Then came ferrous sucrose.
Ferrous sucrose, often called iron sucrose, represented a significant step forward in safety. It's another high molecular weight complex, but it carries a much lower risk of hypersensitivity reactions compared to iron dextrin. Anaphylaxis is rare. However, it is strictly for IV injection only. It's highly alkaline, so giving it IM would cause significant tissue damage and pain. A practical downside is often the dose limitation per administration, typically a maximum of 200 milligrams per day, maybe up to 300 milligrams in some protocols. So correcting a large deficit might require multiple visits. While it became a workhorse, especially for dialysis patients with CKD anemia, there have been some, albeit rare, reports linking it potentially to kidney damage in certain situations.
Okay, safer than dextrin, but still maybe needing multiple doses. What about the two really modern options that seem to have revolutionized parenteral iron therapy, making it much more convenient?
Right. The first of these newer agents is ferric carboxymaltose. This one features a core of ferric hydroxide, which is stabilized by a carbohydrate shell, the carboxymaltose. It's designed to be rapidly taken up by those RE cells we talked about, the macrophages in the liver, spleen, and bone marrow. Studies suggest up to 80% can be taken up directly by the bone marrow for immediate use in making red cells. The huge clinical benefit here is the ability to administer a much larger single dose, up to 1,000 milligrams, or sometimes weight-based, like 15-20 milligram kilograms, diluted in saline and infused over a relatively short period, often just 15 minutes or more. This means many patients can get their entire deficit corrected in just 1 or 2 visits. It has a very low incidence of acute infusion reactions and is generally considered very safe and effective. It's typically not recommended for children under 14, though.
1 or 2 visits versus potentially many more. That's a huge difference. And the absolute latest development in this convenience trend?
That would be iron isomaltoside 1000. This formulation has been available more recently, say since around 2016 in many places. You could argue it's perhaps the most efficient option currently available. The iron is very tightly bound within this isomaltoside matrix. This tight binding results in the release of very little labile or free iron immediately after infusion, which is thought to dramatically minimize the potential for acute toxicity reactions. And because it's so stable and well tolerated, this allows for the highest single dose administration possible, potentially 1 to 2 grams, that's 2,000 milligrams, or up to 20 milligram body weight, enough to correct the patient's entire iron deficit, including stores, in a single short infusion session, maybe over 15 to 30 minutes. It also has a reasonably long plasma half-life of 20-32 hours. So the bottom line is, ferric carboxymaltose and iron isomaltoside 1000 are really the two go-to options now for safe, effective, and incredibly convenient high-dose IV iron replacement.
Okay, that covers treatment. But before we leave iron entirely, we absolutely must address the acute danger, iron poisoning. This is usually, tragically, something that happens with young children, right?
Yes, it remains a leading cause of poisoning deaths in young children, unfortunately. Ingesting more than about 60 milligrams per kilogram of body weight of elemental iron, which might only be a small handful of adult-strength iron tablets, is considered potentially serious toxicity. The initial symptoms are often dramatic and severe. Intense vomiting, sometimes with blood, hematemesis, severe diarrhea, metabolic acidosis develops rapidly, and the child can go into shock. But the really insidious, terrifying part is the potential for delayed toxicity. Often, after those initial awful gut symptoms, the child might seem to improve for a period. There can be an apparent recovery phase, only for them to deteriorate again and potentially die 12 to 36 hours later. This delayed phase is due to progressive internal damage, specifically a necrotizing enteritis, destruction of the bowel lining, and massive liver damage, hepatic necrosis.
So immediate recognition and correct treatment are absolutely critical, life-saving.
Absolutely. Time is critical. The first goal is to stop any further absorption. This might involve gastric lavage, washing out the stomach, potentially with sodium bicarbonate solution in an attempt to make any remaining iron less soluble, or giving things like milk or raw egg yolk orally, hoping they'll bind the iron in the stomach. But once significant iron has been absorbed, the specific antidote, the chelating agent, is desferrioxamine. This has to be given by injection, either IM or preferably IV infusion, and it needs to be continued until the serum iron level falls back down below about 300 micrograms per deciliter. And one crucial point, another chelator, BAL, British anti-lewisite, which is used for some heavy metal poisonings, is absolutely contraindicated here. Why? Because the iron-BL chelate complex it forms is itself toxic. So desferrioxamine is the specific drug of choice.
Right, we have thoroughly covered the primary construction element, iron. Now we need to pivot to the crucial maturation factors, vitamin B12 and folic acid. When these are deficient, they cause a very specific type of anemia called megaloblastic anemia. What exactly does megaloblastic mean at the cellular level? What's going wrong?
Megaloblastic basically means the cells are abnormally large and immature. What you see in the bone marrow are these huge red blood cell precursors, the megaloblasts. And the red cells they eventually manage to produce and release into the bloodstream are also large, macrocytic, and critically, they are defective and have a much shorter lifespan than normal red cells. The fundamental underlying problem, the basic defect in both B12 and folate deficiency, is a catastrophic breakdown in DNA synthesis. This affects not just red blood cells, but any tissue in the body that relies on rapid cell turnover and proliferation, gut lining, hair, etc. But the blood is where we usually see it first and most dramatically.
Okay, let's start with vitamin B12, which historically was often called the extrinsic factor. The history here is another really compelling medical detective story, isn't it?
Well, absolutely. It really began with Thomas Addison describing this mysterious deadly anemia back in 1849. He called it pernicious anemia, meaning harmful or deadly. The huge breakthrough didn't come until 1926. That's when Monod and Murphy famously successfully treated pernicious anemia patients by feeding them large amounts of lightly cooked liver. That work won them the Nobel Prize. George Whipple's work on anemia in dogs was also pivotal around that time. But the conceptual leap came from William Castle, working between about 1927 and 1932. He did these clever experiments showing that normal gastric juice contained something he called intrinsic factor, IF. He hypothesized that this intrinsic factor had to combine with something in the diet, an extrinsic factor, which we now know as B12, for the extrinsic factor to be absorbed. B12 itself, the actual chemical substance, wasn't isolated until much later in 1948.
And the sources are quite unique, aren't they? Because plants don't make it at all.
That's exactly right. Vitamin B12, or cobalamin, is synthesized exclusively by certain microorganisms, bacteria, and archaea, like Streptomyces griseis, for example. Therefore, in our diet, we acquire it only from consuming animal products. Liver and kidney are very rich sources, but also meat, fish, eggs, milk, and cheese contain it. And it's an interesting point that although the bacteria living in our own large intestine, our colonic flora, do synthesize B12, the production happens too far down the digestive tract. We can't absorb it from there. The daily requirement is incredibly tiny, just 1 to 3 micrograms.
Tiny requirement, but absolutely vital functions. Let's discuss the 3 critical metabolic functions of B12. The first one is its intimate relationship with folate metabolism, that infamous methylfolate trap. Explain that.
Right, this interplay is absolutely essential for understanding how both vitamins impact DNA synthesis. B12 acts as a cofactor for an enzyme called methionine synthase. This enzyme does a critical job. It converts the amino acid homocysteine back into methionine. Now, in order to do that conversion, the enzyme needs to take a methyl group, a 1-carbon unit, off of methyl tetrahydrofolic acid, which is methyl THFA. When it removes that methyl group, it regenerates the active form of folate, plain tetrahydrofolic acid, THFA, which can then go off and do its other jobs. Without B12, the methionine synthase enzyme can't function. Therefore, folate gets stuck, it gets trapped in that inactive methyl THFA form. It can't be recycled back to active THFA. It's like having plenty of folate currency in the body, but it's all locked away in a form that can't be spent on DNA synthesis. That's the methylfolate trap.
Okay, so the body might have lots of folate around, but it's functionally useless because it's trapped. And this trapped folate then directly impacts DNA production. How exactly?
Because that active THFA, the non-methylated form, is absolutely required as a carrier for 1-carbon units in several other crucial reactions needed for DNA synthesis. Most importantly, it's needed to generate thymidylate, one of the 4 essential building blocks, bases, for DNA. If THFA is trapped as methyl THFA because of B12 deficiency, then thymidylate synthesis grinds to a halt. Without thymidylate, you simply cannot assemble new DNA strands properly. Cell division falters, leading to those large abnormal megaloblasts in the marrow.
Okay, that covers the DNA synthesis link. And the third critical function, the one that is unique to B12 deficiency and really distinguishes it clinically from folate deficiency, maintaining neurological integrity.
This is absolutely paramount. B12 is vital for the health of the nervous system through at least 2 key pathways. One involves the conversion of methylmalonic acid to succinic acid. In B12 deficiency, methylmalonic acid builds up, and this accumulation is thought to contribute somehow to the demyelination process, the breakdown of the protective myelin sheath around nerves. But perhaps even more critically, B12 is required for the synthesis of S-adenosylmethionine, or SAM. SAM is the body's major methyl group donor, and it's absolutely essential for countless methylation reactions, including the synthesis and maintenance of phospholipids and myelin itself. If SAM synthesis fails due to lack of B12, the structure and function of the myelin sheath degrade. This leads directly to the neurological damage we see things like subacute combined degeneration of the spinal cord, peripheral neuropathy, nerve damage in the limbs, and even cognitive changes or dementia.
That distinction, the fact that serious neurological symptoms only appear with B12 deficiency, not pure folate deficiency, that has to be the single most important clinical lesson here, doesn't it? Okay, let's quickly revisit that complex absorption mechanism involving intrinsic factor.
Right, B12 absorption is a highly specific, multi-step, energy-dependent process. It's not simple diffusion. First, B12 in food needs to be released from the food proteins. Gastric acid and pepsin in the stomach do this. The freed B12 then immediately binds to intrinsic factor, IF. IF is a glycoprotein that is secreted by the very same parietal cells in the stomach lining that produce stomach acid. This B12-IF complex is crucial. It's resistant to digestion, and it travels all the way down through the small intestine to the very end, the terminal ileum. Only there, in the terminal ileum, are there specific receptors on the intestinal cells that recognize and bind to the B12-IF complex. The complex is then actively transported into the cell. So the problem in classic Addisonian pernicious anemia is that the patient's immune system mistakenly attacks and destroys those gastroparietal cells. This leads to a complete absence of intrinsic factor secretion. Without AF, the body simply cannot absorb dietary B12 at the physiological levels needed, no matter how much B12 the person eats. Absorption drops to maybe 1% or less via passive diffusion, which isn't enough.
Okay, so IF is the essential key to get B12 through the door. Once it's absorbed, how are our B12 stores managed? It lasts a long time, right?
Yes, B12 is transported in the blood, primarily bound to a transport protein called transcobalamin 2, TCII, and storage is incredibly efficient. The liver is the main storage depot, holding maybe 2/3 to 4/5 of the body's total B12 store, which is typically around 2 to 8 milligrams in a healthy adult. The body also employs a very effective enterohepatic circulation for B12. It's secreted into the bile, but then most of it gets reabsorbed further down in the ileum if AF is present. This recycling system is so effective that if you had normal B12 stores and then suddenly stopped all dietary intake completely, like in a strict vegan diet without supplements, it would typically take a remarkably long time, maybe 3 to 5 years, to actually deplete those stores and develop clinical deficiency.
Wow, 3 to 5 years is a huge time frame. But crucially, if the underlying problem is a lack of intrinsic factor, then deficiency develops much, much faster, right? Because that whole recycling loop fails. And that's why injections are absolutely essential for treating pernicious anemia.
Precisely. If intrinsic factor is absent, the oral route is essentially useless for replacing B12 stores effectively. You must bypass the gut. For treatment, injectable B12 is the standard. Hydroxycobalamin is often preferred over the older cyanocobalamin form for injections. Why? Because it binds more tightly to proteins in the body and is therefore retained longer, giving more sustained levels. The typical treatment regimen involves an initial loading phase, maybe 1 milligram injected daily or every other day for a week or two to rapidly replenish stores. This is followed by long-term maintenance therapy, usually 1 milligram injected perhaps every 1 to 3 months, often for the rest of the patient's life, to maintain adequate levels as the absorption defect persists.
What about that newer form, methylcobalamin? Is it considered superior, especially for tackling the neurological symptoms directly?
Methylcobalamin is one of the active coenzyme forms of B12 in the body, the one directly involved in that methionine synthase reaction, and thus SAM synthesis. Because of this direct link, it's often promoted heavily, especially in the supplement market, for specifically addressing neurological defects like peripheral neuropathy. The rationale seems logical. However, while it's widely used, often as an oral or sublingual supplement, it's still not universally recognized in many formal clinical treatment guidelines as being definitively superior to injectable hydroxycobalamin for correcting the deficiency state itself, including the neurological aspects. More research is probably needed, but hydroxycobalamin remains the gold standard injectable form for proven deficiency requiring parenteral therapy.
Okay. Now, let's hammer home what you call the absolute cardinal rule of Haematinics when treating someone diagnosed with B12 deficiency.
Yes, you must always consider co-administering folic acid, and usually an iron preparation as well, when you start aggressive B12 replacement therapy. Why? Because the B12 treatment works incredibly well and very fast. Within just a couple of days, the bone marrow kicks into high gear. What we call brisk hemopoiesis begins. This sudden, massive production of new red blood cells rapidly consumes the body's existing, often marginal supplies of the other essential building blocks, namely folate and iron. If you don't provide these concurrently, you risk quickly unmasking or inducing secondary deficiencies of folate and iron, which could then blunt the patient's overall recovery from the anemia, even though you're giving plenty of B12. So always think about the other players.
Right, anticipate the demand. Okay, let's switch gears now to the other maturation factor. Folic acid, also known as pteroyl glutamic acid, or PGA. It causes the same megaloblastic anemia, fixes the same DNA problem, but seems to work on a very different biological clock compared to B12.
Exactly. Folic acid was first recognized as a factor needed to treat certain anemias of pregnancy in India by Dr. Lucy Wills back in the 1930s. It was initially called the Wills factor. It was later isolated from spinach leaves in 1941, hence the name folic from the Latin folium for leaf. Good dietary sources include liver again, but also green leafy vegetables like spinach, obviously, eggs, meat, and yeast. The daily requirement is actually quite a bit higher than B12 in mass terms, though still small, maybe less than 0.1 milligrams, 100 micrograms needed, though the recommended daily intake is often set higher, around 0.2 milligrams or 200 micrograms. And this requirement jumps significantly, up to maybe 0.8 milligrams or 800 micrograms per day during periods of high demand like pregnancy and lactation.
And the storage time, or rather the lack of it, that's the key vulnerability compared to B12, isn't it?
Absolutely. That's the critical difference in terms of how quickly deficiency can develop. The total body store of folate is surprisingly meager, only about 5 to 10 milligrams in total. This small store gets depleted incredibly fast if intake stops. It typically lasts only about 3 to 4 months without any external supply. So, if you were to stop eating folate-rich foods completely today, you could potentially become clinically deficient in just a quarter of a year. Compare that to the 3 to 5 years it takes to deplete B12 stores. It highlights how crucial continuous dietary intake of folate is.
Okay, 3-4 months versus 3 to 5 years. Big difference. Now, before folic acid can actually do its job, it needs to be activated in the body, doesn't it?
Correct. The folic acid we get from diet or supplements isn't the active form. It needs to be reduced, chemically modified into tetrahydrofolic acid, THFA. This happens in a two-step process that requires enzymes called folate reductase, and more importantly, dihydrofolate reductase, DH. THFA is the biologically active coenzyme form. It functions as a carrier, picking up and transferring single carbon units like methyl or formyl groups in various essential metabolic reactions. Its key functions include, number one, working alongside B12 in that methionine synthase reaction, which regenerates both methionine and free THFA, avoiding the folate trap. And number two, and critically for DNA, THFA derivatives are essential for generating thymidylate, that DNA base we mentioned earlier. Now here's the key point about that second function. The reaction that generates thymidylate actually consumes the active folate coenzyme. It oxidizes it back to dihydrofolate, DHFA. This DHFA then needs to be reduced back to THFA by the DH-phrase enzyme to be used again. The fact that this crucial DNA synthesis step consumes active folate and relies on DH-phrase for regeneration is precisely why rapidly dividing cells are so exquisitely sensitive to DH-phrase inhibitors. The classic example is the chemotherapy drug methotrexate. It works by potently blocking the DH-phrase enzyme. This leads to an acute functional folate deficiency specifically in rapidly dividing cancer cells, and unfortunately also in healthy rapidly dividing cells like bone marrow and gut lining, stopping their DNA synthesis and proliferation.
Fascinating mechanism. Okay, what are the main causes and the typical manifestations of folate deficiency then?
The most common cause worldwide is probably inadequate dietary intake, especially common in the elderly, individuals with chronic alcoholism or people on very restricted diets lacking fresh greens. Malabsorption syndromes like celiac disease or tropical sprue can also impair folate uptake. Increased demand is another major factor, pregnancy and lactation, periods of rapid growth, or conditions with high cell turnover like chronic hemolytic anemias. Certain drugs can also interfere with folate metabolism or absorption, notably the anti-epileptic drug phenytoin, and sometimes long-term use of oral contraceptives has been implicated. The manifestations, well, hematologically it's megaloblastic anemia, indistinguishable on a blood smear from B12 deficiency. You also see epithelial damage like glossitis or smooth tongue, similar to B12 deficiency.
Right, but the absolutely critical difference, which we need to keep repeating because it's so important clinically.
Neurological symptoms do not occur in pure folate deficiency. This is the key differentiator from B12 deficiency. Why? Because folate's role in the nervous system seems much less direct than B12's role in SAM synthesis and myel maintenance. However, where folate deficiency does have a devastating neurological impact is during pregnancy. We now know conclusively that maternal folate deficiency, especially early in gestation, is a major risk factor for severe birth defects in the offspring, specifically neural tube defects like spina bifida and anencephaly. This discovery is why prophylactic folic acid supplementation, typically around zero point 0.4 to 1 milligram per day, is now universally recommended for all women planning pregnancy and during the first trimester. It's been incredibly successful in reducing the incidence of these devastating defects.
A major public health success story. Okay, now let's revisit that final, absolutely life-saving rule about prescribing these two maturation factors together, the danger zone.
Yes, this cannot be stressed enough. Folic acid should never be given alone, meaning without confirming B12 status first to a patient who might have underlying B12 deficiency, especially not in high doses. Why is this so dangerous? If you give high-dose folic acid to someone who is actually B12 deficient, the folic acid can partially overcome the metabolic block, the methylfolate trap, enough to allow some DNA synthesis to resume. This will often correct the anemia, the blood picture might improve, which can mask the underlying B12 problem. However, this sudden surge in DNA synthesis and red cell production places a massive demand on the body's already severely limited B12 supply. The scarce B12 gets preferentially shunted towards making red cells. This effectively diverts the last remaining B12 away from the nervous system, where it's critically needed for myelin maintenance via SAM synthesis. The tragic result can be an acceleration and worsening of the underlying neurological damage, potentially leading to irreversible spinal cord degeneration, even while the blood count looks better. It's a clinical nightmare scenario. Always rule out or treat B12 deficiency first if suspected, or give them together if unsure.
A critical point. Okay, one last thing on folate. What is folinic acid and when is it used? It sounds similar, but it's different, right?
Right. Folinic acid, which is also known as leucovorin or sometimes citravorin factor, is chemically 5-formyl THFA. The key difference is that it is already an active coenzyme form of folate. It does not need the DH-phrase enzyme to become active. Because it bypasses DH-phrase entirely, its primary clinical use is not for treating simple dietary folate deficiency. Instead, it's used strategically as a rescue agent, specifically to counteract the toxic effects of the DH-phrase inhibitor drug, methotrexate. When patients receive high-dose methotrexate for cancer therapy, giving folinic acid afterwards allows their normal healthy cells, like bone marrow and gut lining, to bypass the methotrexate block and continue making thymidylate and DNA, thus mitigating some of the severe side effects of the chemotherapy without compromising its anti-cancer effects significantly. It rescues the normal cells.
Okay, we've covered the essential building blocks, iron, B12, folate. Now we turn to the master regulator, like a command signal for red cell production itself. Erythropoietin, or EPO. This isn't a nutrient we eat, it's a hormone the body makes.
Exactly. EPO is a specialized signaling molecule. Chemically, it's a sial-like glycoprotein hormone, a protein with sugar chains attached, and it's quite large, with a molecular weight around 34,000 daltons. It's produced predominantly, about 90% of it, by specialized cells in the kidney, the peritubular interstitial cells. These cells act like the body's primary oxygen sensors. When these kidney cells sense a drop in oxygen delivery, which happens in anemia, fewer red cells carrying oxygen, or hypoxia, low oxygen in the air like at high altitude, they rapidly ramp up the production and secretion of EPO into the bloodstream.
And when that EPO signal reaches the bone marrow, what exactly does it command the marrow to do?
It acts very specifically on the early precursor cells destined to become red blood cells, the erythroid progenitor cells, like the BFUE and CFUE, burst-forming unit erythroid and colony-forming unit erythroid. EPO binds to specific receptors on the surface of these cells, which triggers an internal signaling cascade involving JAK-STAT pathways. The result is multi-pronged. EPO stimulates these progenitor cells to proliferate, divide more rapidly. It induces them to start synthesizing hemoglobin. It speeds up their maturation process through the various erythroblast stages, and it hastens the release of slightly immature red cells called reticulocytes from the marrow out into the circulation. Essentially, EPO is the accelerator pedal for red blood cell production. More EPO means faster, more intense production.
Right. Now, the primary clinical application for synthetic recombinant human EPO drugs like epoetin alpha or epoetin beta is overwhelmingly in patients with chronic renal failure, or CKD. Why does kidney failure typically lead to severe anemia, even if the patient has plenty of iron and vitamins available?
It's a direct consequence of the kidney being the main EPO factory. In the vast majority of patients with significant CKD, their damaged kidneys, specifically those failing peritubular cells, simply cannot produce enough endogenous EPO anymore. The production lines in their bone marrow might be perfectly capable of making red cells. They might have adequate iron, B12, and folate stores, but the essential command signal, the EPO, is missing or drastically reduced. So the anemia of CKD is primarily an anemia of underproduction due to EPO deficiency. EPO therapy is used simply to replace that missing hormonal signal.
Okay, that makes sense. Now, the treatment target for EPO therapy in CKD is quite specific, and interestingly, it's deliberately kept subnormal. You mentioned they typically aim for a hemoglobin level between 10 and 11 grams per deciliter, with a hard maximum ceiling usually around 12 GDL. Why not just aim to bring the hemoglobin all the way back up to the normal physiological range, say 13.5 GDL or higher?
This is a really critical safety point that was established through several large, important clinical trials conducted years ago. Those trials specifically tested whether pushing hemoglobin levels back up to the normal range, around 13.5 GDL or higher, in CKD patients using higher EPO doses would provide further benefit. The results were actually the opposite, and quite concerning. They found that targeting these higher normal hemoglobin levels resulted in significantly higher mortality rates and an increased risk of serious cardiovascular events, like stroke, heart attack, and blood clots. The physiological reason is thought to be related to blood viscosity. As you increase the hemoglobin and hematocrit, the percentage of blood volume taken up by red cells, the blood becomes thicker, more viscous. This increases peripheral vascular resistance, puts more strain on the heart, and makes blood more prone to clotting. So the clinical danger is real. Increased risk of stroke, uncontrolled high blood pressure, hypertensive episodes, serious thromboembolic events, blood clots. Especially concerning is clot formation in the arteriovenous AV shunts or fistulas that dialysis patients rely on for their treatment.
Therefore, the current standard of care is to use the lowest dose of EPO necessary to maintain the patient's hemoglobin in that safer, slightly lower range of 10-11 GDL, maybe up to 12 GDL max, primarily aiming to avoid the need for blood transfusions and alleviate the worst symptoms of anemia without incurring the risks associated with normalizing the HB completely.
Got it. Keep it in that specific target zone. And just like we discussed with starting B12 therapy, if we're using EPO to really ramp up red cell production, we absolutely need to anticipate the increased demand for the raw materials, especially iron.
Absolutely critical point. When you hit the accelerator hard with EPO, the bone marrow's demand for iron can skyrocket almost overnight. Most CKD patients starting EPO therapy either already have low iron stores or quickly develop what's called functional iron deficiency, meaning they might have some iron in storage, but they can't mobilize it fast enough to keep up with the intensely stimulated erythropoiesis.
Yeah.
Therefore, achieving an optimal response to EPO therapy requires concurrent, and often quite aggressive, iron supplementation, frequently needing parenteral IV iron to provide the marrow with enough fuel to meet the EPO-driven demand. Without adequate iron, the EPO just won't work effectively.
Okay. Let's quickly look at the main preparations used. What's the practical difference between the standard epoetins, alpha and beta, and the longer-acting version, darbepoetin alpha?
Epoetin alpha and epoetin beta are essentially copies of the natural human EPO molecule, produced using recombinant DNA technology. They have a relatively short biological half-life in the body, typically around 6 to 10 hours after injection. Because of this short duration, they usually need to be injected fairly frequently, often 3 times per week, either subcutaneously, under the skin, or intravenously, usually during dialysis. Darbepoetin alpha represents a significant pharmaceutical modification. It's what's called a hyperglycosylated analog of EPO. Basically, scientists engineered it to have extra sugar chains attached to the protein structure. This added glycosylation makes the molecule more stable and resistant to breakdown in the body, giving it a much longer biological half-life, typically around 24 to 36 hours, sometimes even longer.
So the main advantage of darbepoetin is purely about convenience and potentially better patient compliance.
Precisely. That much longer half-life means darbepoetin only needs to be injected perhaps once a week, or sometimes even only once every 2 weeks to maintain stable hemoglobin levels. For patients, especially those not on dialysis who have to self-inject or come to a clinic, reducing injection frequency from 3 times a week down to once a week or less is a massive improvement in convenience and adherence to therapy.
Makes sense. Finally, let's just quickly revisit the adverse effects of EPO therapy. You mentioned they aren't really due to the drug itself being rejected by the body, but rather they're consequences of the physiological changes it causes, particularly that increase in blood viscosity.
That's generally true. These recombinant EPO products are typically non-immunogenic or only very weakly immunogenic, meaning the body rarely mounts a significant immune response against the hormone itself. Although a rare condition called pure red cell aplasia due to anti-EPO antibodies can occur, it's very infrequent. The main adverse effects and dangers we worry about stem almost entirely from the intended pharmacological effect, raising red blood cell count. As we discussed, by rapidly increasing the red cell mass in hematocrit, you inevitably increase blood viscosity. This can directly lead to or exacerbate hypertension, high blood pressure, sometimes causing severe hypertensive episodes. It increases the risk of thrombotic events, deep vein thrombosis, pulmonary embolism, stroke, heart attack, and thrombosis of those vital AV accesses in dialysis patients. Occasionally, seizures have also been reported, possibly related to rapid rises in blood pressure. So patients on EPO require very close monitoring of their blood pressure and hemoglobin levels, especially ensuring they don't overshoot that target HB range and creep up towards that potentially unsafe 12 GDL threshold or beyond.
Okay, we've explored the intricate mechanics of iron absorption, the crucial differences and dangers with B12 and folate, and the powerful regulatory role of EPO. Let's try to bring all this knowledge together now by revisiting that clinical scenario we touched on earlier. Remember the setup. A 40-year-old lady comes in complaining of persistent severe weakness and fatigue. Her blood work shows a low hemoglobin of 7.6 GDL. She tells you she's been diligently taking a liquid Haematinics syrup she bought over the counter. It contains ferrocomonium citrate, a form of iron, plus some folic acid and B12, taking it every single day for the past 2 months, but she feels absolutely no better. Her blood smear is examined and confirms a microcytic hypochromic picture, which is classic for iron deficiency anemia. Now, here's the absolutely key piece of history she mentions. She also takes a rabeprazole tablet every day and has been doing so for the last 2-3 years for chronic heartburn or acid reflux.
Right. This is just a perfect textbook example illustrating why understanding the underlying mechanisms of absorption is so vital, not just knowing which pills treat which deficiency. We have a clear diagnosis here: iron deficiency anemia. The symptoms fit, the low HB fits, and the microcytics, small cell, hypochromic, pale cell appearance on the blood smear confirms it's likely due to lack of iron for hemoglobin synthesis. The fact that she's been taking an oral iron preparation, even if it's maybe not the best form, ferrocomonium citrate, for 2 whole months with 0 clinical or hematological improvement strongly suggests the problem isn't lack of intake, but rather a failure of absorption. Something is blocking the iron from getting in.
And based on our deep dive in Section 2, that rabeprazole immediately jumps out as the prime suspect, the likely culprit.
Well, it is the absolute key link here. Rabeprazole is a proton pump inhibitor, or PPI. These are extremely potent drugs designed to drastically shut down acid production by the parietal cells in the stomach. Their entire purpose is to make the stomach environment highly alkaline to treat conditions like acid reflux or ulcers. Now let's recall our iron absorption mechanics for inorganic iron, like the ferrocomonium citrate she was taking. We establish it must be dissociated from complexes, and critically it must be reduced from the ferric Fe3+ state down to the ferrous Fe2+ state before it can be transported into the intestinal cell by the DMT1 transporter. This crucial reduction step absolutely requires an acidic environment and the presence of reducing substances. By making the stomach highly alkaline, the rabeprazole is doing 2 things. It's rendering the inorganic iron much less soluble, and it's strongly opposing that necessary chemical reduction to the absorbable Fe2+ form.
So the iron is getting into her stomach when she takes the syrup, but it's hitting this alkaline wall created by the PPI. It's physically prevented from undergoing the chemical change needed to become the absorbable Fe+ form that can actually utilize the DMT1 transporter in the duodenum. She's essentially been taking an expensive, ineffective placebo for 2 months because of the drug interaction.
Exactly. The concomitant long-term use of the potent antacid medication is almost certainly preventing the absorption of the oral inorganic iron entirely. This case beautifully illustrates why simply knowing iron treats iron deficiency isn't enough. You have to understand the fundamental role of gastric acid in inorganic iron absorption to diagnose and manage this kind of treatment failure effectively.
So given this understanding, what's the appropriate treatment strategy here? It's not necessarily to immediately jump to recommending expensive, potentially painful parenteral IV iron, is it?
No, not as the very first step. The most targeted, logical first step is to try and eliminate the impediment to absorption. If her underlying gastric condition, the reason she's on rabeprazole, allows for it, could the PPI be safely stopped, at least temporarily, or perhaps switched to a less potent H2 blocker, or taken at a different time relative to the iron? If the acid suppression can be reduced, she would likely start responding promptly to a standard oral iron preparation, perhaps switching her to a more reliably absorbed ferrous sulfate tablet. Now, if her underlying condition absolutely mandates the continued use of the powerful PPI therapy and reducing acid suppression isn't an option, then yes, parenteral IV iron would become necessary because we've effectively proven her gut cannot absorb oral iron adequately in that alkaline environment. But addressing the drug interaction first is key.
This has been an incredibly thorough deep dive. I feel like we've really moved far beyond just the basic nutritional facts today. We've covered everything from the almost intuitive historical reverence for iron to its specific distribution within the body, remembering that crucial 6% parenchymal fraction impacting every cell. We dug into the complex, self-regulating ferritin curtain controlling absorption and charted the evolution towards much safer and more convenient injectable iron options like iron isomaltoside.
And we really mastered the maturation factors too, didn't we? Detailing the absolute necessity of intrinsic factor for B12 uptake, truly understanding why B12 deficiency leads to that dangerous methylfolate trap and neurological damage. And most critically, internalizing that cardinal safety rule. Never give folic acid alone if B12 deficiency is possible, because of the risk of worsening irreversible nerve damage. And finally, we clarify the vital regulatory role of EPO, understanding its mechanism, and importantly, why the target hemoglobin in CKD patients must be kept deliberately subnormal to avoid those serious, potentially fatal thromboembolic events.
Absolutely. So, as we wrap up this deep dive, let's leave you, our listeners, with one final thought to chew on, building on that systemic nature of iron we discussed. We know the body conserves iron tenaciously, almost hoarding it, and we know that iron deficiency, because of that parenchymal iron component, ultimately affects the function of virtually every cell by impairing essential cellular enzymes like the cytochromes involved in energy production. So, considering this profound systemic impact, what subtle long-term non-blood health implications, things like perhaps slightly impaired cognitive function, reduced mitochondrial efficiency leading to subtle fatigue even without frank anemia, maybe altered immune responses, what might chronic low-grade iron deficiency, the kind that maybe doesn't even fully drop the hemoglobin into the anemic range, be silently causing in otherwise seemingly healthy people. Implications that are frequently missed because we tend to focus almost exclusively on the classic blood indices and the overt symptoms of weakness and fatigue. Something to maybe research further as you apply this deeper mastery of haematinics in your own thinking or practice.